Well, third time is a charm. My guest and I have tried to resolve some audio and visual deals with my recording studio. So here we are on Zoom recording this interview. And I know you're going to enjoy this discussion as much as I'm going to enjoy recording it. So let's dive right into this. Dr. Tara Gunther lives in Pittsburgh, Pennsylvania, and she lives with her husband, Matthew, and her two children, Abby and Kenny. Abby's 13, Kenny's 11. She enjoys walking, strength training, cooking, reading, crocheting, and hiking. Tara believes that self-care and interpersonal growth are non-negotiable parts of life. Tara received her master's and doctoral degrees in clinical psychology from the Illinois School of Professional Psychology and completed her postdoctoral internship at Western Missouri Mental Health Center in Kansas City, Missouri. Having completed programs in physician leadership at both T.H. Chan School of Public Health at Harvard and Block School of Management at the University of Missouri, Kansas City, she worked extensively in the field of primary care behavioral health integration. She developed expertise in working with patients in sleep medicine, gastrointestinal disorders, diabetes, and primary care. Tara has also lectured on trauma and how to implement trauma-sensitive practices within medical and community settings. Tara is a national board certified health and wellness coach through Integrative Health Coach certification of the University of Arizona, Andrew Weil Center for Integrative Medicine. And she is also a certified coach in Cynthia Thurlow's intermittent fasting IA45 masterclass. And that is how Tara and I connected and met, was through IA45. She currently runs a private practice where she specializes in helping women with weight loss, anxiety, and stress management, as well as integrative health and wellness coaching. Tara, welcome to the show.
Thank you. Very excited to be here.
Excited to have you. And I want to dive into your background in trauma and specifically how can healthcare workers, doctors, nurses, even personal trainers or nutritionists, how can we in the health community be more sensitive to past trauma? And as I was telling Tara, and I've spoken with the listeners about before, I have my own history of this and have gone through, a process of receiving therapy over the years, which has helped me immensely. But I became interested in how it can affect us, particularly in midlife and beyond, how it can reemerge, and then once again, how we can help individuals and be sensitive as we're working with them. But before I get into all of this, I would love to get your background story, Tara, on how you came to be working in the field of trauma.
Okay, great. It's interesting how things come so full circle. Just having met you through the IA45, which is very health and wellness focused, but so many of our coaches were interested in trauma, so we gave a little informal talk on trauma a few weeks ago. And so, when you think about, or when I think about my history, I mean, it's full circle. So I, of course, grew up in rural Wisconsin, had my own struggles with weight and wellness and as a young child, and probably some minor trauma along the way with that. And then when I was in graduate school, I decided to really focus in on health psychology, because even then, even in my early 30s, which is when I went back to grad school, I was intricately interested in the connection between mind and body, and how you just really can't tease the two apart. And so then, fast forward after grad school, my first major career move was was working as a health psychologist for Truman Medical Centers in Kansas City, Missouri. And while I was there, the first clinic, so they were a several hospital safety net hospital system. They were really interested, and this is I'm trying to think what year this was, probably 2008. They were very interested in putting behavioral health services in different medical specialties, and they've been trying to do it. And the issue with it has always been how to pay for it. And so we were sort of at the cutting edge trying to implement these behavioral health services before there were behavioral health coaches. And so anyway, I was kind of at the ground level and was put into sleep clinic, which was one of the best experiences of my career because sleep is so critical. And then, of course, if you think about it, if individuals have trauma, they often have trouble and difficulties with sleep, depending on what's happening. So early on, it just became evident and that there was so much trauma interrelated with individuals' health issues. And of course, the patients that we were seeing had complex trauma histories, complex medical conditions, and it just the same it was the sort of the same development in each different medical specialty that I worked in. So whether it was sleep, whether it was HIV, whether it was sickle cell, whether it was primary care, later on in my career, diabetes and GI, all of these different medical specialties that I spent time trying to develop services within, you could never really pull out the trauma piece. So here I was trying to do these, brief interventions to help them, typically with the provider saying, hey, some of the behaviors are a problem, fix it. And then what you would see is that this is a very complex issue. And then along the way of my career track, my boss at the time, who was the head of the Truman Medical Centers had a very robust mental health, behavioral health division, about 450 employees, multiple programs. And so we had this medical part of the system, and then we had the behavioral health side of the system. And she became involved in the early stages of trauma-informed care. Missouri was one of the first states to step in and really start to look at trauma-informed care as a really important aspect of the way that we are helping clients. And so then here I had this sort of health psychology side of my practice, and then started to move into this trauma-informed world. And what trauma-informed care is it was looking at how we approach our clients and sort of and the way that we are treating them and how we might be re-traumatizing them, and looking at our client population not from the lens of what is wrong with you, like why are you smoking, why are you drinking, why aren't you taking your meds, why do you have all these issues, instead of that, looking at what happened to you. And so it was a complete cultural shift. And in my boss, Marsha Morgan, and she is no longer, she has since retired, but now is a consultant and still heavily involved in this world. She had said, and I remember this decades ago, saying, this is probably the most important work I will ever do. I've been in the business of behavioral health for 40 years, but this is important stuff. This is what we really need to be looking at. And so then as an organization, we started to realize, hey, we're treating all this anxiety and depression, or we're trying to treat it, and people are not getting better. And what we started to even look at in the behavioral health setting was that we weren't addressing the underlying trauma. So then, and by that point I had been promoted and I was section chief of psychology. And so then I was still doing clinical work, but started to do more of the program development. And we hired in a trauma specialist, a trauma psychologist from one of the VAs, and had her help us build a PTSD, or a trauma specific wing, if you will, and trying to treat trauma specifically. So the difference, we had sort of two arms of our focus. We had creating culture change with staff and really trying to train every layer of the organization on trauma-informed care and how to be trauma sensitive. Meanwhile, we had a separate arm of training our clinicians on trauma-specific treatments, so that when we started, because as you start to become trauma-informed, you are going to become so much more aware of how much trauma is around you, and then what were we to do to help these clients. So it was really a dual focus. And so I'm excited to be on this call because I get to talk about something that I haven't done as much in the past few years in terms of the training. And and it was a real passionate part of my career for a while when I was in Kansas City, and learning not only how this is such a global issue, and then how do we even begin to chip away at it. So Kansas City was fun because we were there at the sort of the beginning of this trauma-informed care movement. I shouldn't say we, but my boss at the time, she was spearheading, like we had trauma informed Kansas City. So we started to draw on the police department, schools, different public services, and then also training other mental health institutions in the area of trauma-informed care. So that's in a nutshell. I mean, we have a lot to cover today, so I hope that answers your question.
It fascinates me, though. I know you had spoken in the meeting for IF45 about that connection to when they would try to do a sleep study and how so
Oh,
many would
yes.
drop
Mm-hmm.
out because of this
Yeah.
past trauma. And maybe they're, like I said, you could be unaware and having these triggers. I know I was largely unaware for a long time. What were you seeing in those sleep studies?
So, I mean, we were seeing this across, and again, once your lens has shifted, you see it everywhere. But specifically in the sleep clinic, the part that's so amazing about how the shift that we saw when I gave a 30-minute presentation, just 30 minutes. That's all they could afford in terms of time during one of their staff meetings. And so for the sleep clinic, if you imagine, to people, and if individuals have never had a sleep study, I mean, they're putting electrodes all over your head. They're typically putting some sort of strap over your body, and then they're asking you to sleep. And while we watch you all night long, and it's just such, even that is so uncomfortable, right? But think about someone who's had some sort of trauma, any number of kinds of traumas, that being watched, being strapped, um, having things placed on your body, it can all be really triggering. And so I no longer recall what the exact statistics were, but I remember it was a staggering amount of individuals that would not complete a study within a month's time. And again, this is by my memory, I want to say it was like 50 a month or something like that would leave AMA. They just could not make it through the night and they would get up and leave, which is a tremendous amount of, effort and patient and care that was, the results were just being sort of lost. And 30-minute presentation on just helping that staff understand that how they were relating to the client, how they were relating to the patient, behavioral cues, what they were saying. So I just gave this generic sort of talk, and then they knew how to apply it specifically to their clinic. It dropped down to about 1 or 2 a month. It was staggering. Again, I don't remember the exact statistics, but just in the staff's ability to shift their own lens and perspective dramatically improved a patient's ability to complete the study. I mean, there are so many examples. I mean, we have examples of, someone would come in and get a pressure cuffed in the ER, and that example started to make the person combative. And here, this poor individual who's coming into the emergency side of the medical side, the staff are ignoring them because you know what? They need that number, right? They need to have that pressure cuff number, even though the client is getting very obviously agitated, and all the way to the horrible side where this patient ended up being so combative in their eyes. They called over the behavioral health team. He ended up being hospitalized on the behavioral health inpatient psych. But again, when he got to the inpatient side, do you know what they did again? Put that pressure cuff on him again, reignited his reaction, and it turned into this really ugly scenario. And all it really boiled down to is that the staff was so focused on what they had to do and what they had to get done and ignored all of the cues and probably even what the individual was saying. And so trauma-informed care, I mean, that's where it's just such an important part of our practice that, we all have a job to do. We all have information that we want to share, or we have, outcomes that we're trying to get to with a visit with a client or a patient, but not at the expense of their experience and paying attention to what's happening to them. And so that's why this training is so important. I
I
know I just
agree.
went off on a little bit of a soapbook or soapbox, but yeah.
No, it's great. I agree 100%. I could actually see why the sleep study. I mean, I got anxious when you're describing it and how people are watching
Mm-hmm,
you and you're getting hooked up. And so I could see
mm-hmm,
that would make anyone anxious. And then if you had, this past trauma, how that could really reignite it. I first
yeah.
really became aware of this as a personal trainer, and as a personal trainer, it's the same thing. You got a job to do. And so I'd be like, okay, we're going to do exercise A, B, C. It's going to go in this order. And I'd have the sets, the reps, the whole thing down.
Mm-hmm,
And I remember it was actually a gentleman I had. who had, I didn't realize it at the time because he hadn't shared with me, had PTSD from combat situations and also certain flying situations that he was in where he had, near death experiences. And I was having him on the leg press. I'll never forget it. And we were doing a higher rep set on the leg press. And suddenly I saw him shake. And it was like his face went blank. He was somewhere else. It was like he was back in that plane and his fists were clenched. His jaw was clenched. And I was completely unprepared as a personal trainer. I didn't know what was happening. Once he shared a little bit more with me, and now looking back in retrospect, I understand exactly what was happening. But I agree, people need to be personal trainers. That's an intimate job. You're working with somebody's physique. You're placing them in uncomfortable situations where their heart rate's going to go up, they're lifting heavier weight, there's some demands there, and I think that that can easily be triggering. But what I wanted to unpack a little bit is the word trauma is so broad these days, I think. So we think of PTSD, we think of
Mhm.
chronic, we think of big traumas, little traumas, layers of traumas. What is trauma, and is trauma different from PTSD?
Good question. So I think, yes, I mean, I think of it on almost a continuum. So trauma is very individual. So what might be traumatic to one person is maybe not traumatic to someone else. Um, the so that just to clarify the terminology, for instance, so trauma can be anything that overwhelms the person that maybe puts them into a flight, fight, freeze kind of physiological response. But whether we develop PTSD or PTS. So PTS, post-traumatic stress, is an acute stress reaction that lasts maybe a couple days to a couple weeks after something very, a big event, if you will. And PTSD, how it develops into a disorder is when it's over several months. And you can have, reoccurrent, you can have acute. And to get into the nitty gritties of actually diagnosing someone, there's a whole set of criteria. And I think, we hear PTSD, I have PTSD from this, or I have PTSD from that. I mean, that's people do throw the term around pretty liberally. Um, but I think it's definitely a certain set of criteria about how they are being triggered, like that gentleman you were describing. Like, he wasn't there, so he was probably having maybe a flashback, or he was, sort of in sensory overload. And so there's a whole set of criteria that someone would carry to have post-traumatic stress disorder after a certain period of time after the event. And the other piece of that is, though, is that trauma can lie dormant, and people's response to trauma is so individualized. I mean, it can be based on their temperament, their upbringing, all sorts of factors can go into whether or not someone would have developed PTSD or not. So someone could have had very traumatic events in their childhood and not ever qualified or met criteria for the diagnoses, but then something in their adulthood triggers it, which may not even have been another traumatic event, but now suddenly they're experiencing symptoms that would qualify for the diagnosis. Does that make sense?
Oh, it makes
I hope
perfect
I
sense.
clarified.
Perfect
Yeah.
sense. I know with myself, to get a little vulnerable here and transparent, when I got my diagnosis of PTSD, I argued with my therapist. I said, no, I don't have that because this didn't happen and that I wasn't in a war and I wasn't in combat. And it
Mhm.
took some time for us to unpack that. And I remember it's like months later that I was acknowledging it. And so I think sometimes we, especially as women, so we have the events that trigger this, and then we start raising families, having careers. It's easy to push that back, and I'm really good at this. Like, oh, we're just not going to think about this. We're going to fill our
Mhm.
time over here with long runs and running the kids to sports, and we're not
Right.
acknowledging it in our lives. And then until it finally just emerges, something like you said, there's maybe something that triggers it. I've often thought, And I don't know the research on this, but I've often thought sometimes when women are going through those hormonal shifts and they're getting these hot flashes and all these physical symptoms, because that was about the time where I started to go, something's not quite right here.
That's fascinating. Yeah, and I don't know if there's specific research about that, and that would be a wonderful area to have research. But I do believe, and I've seen this so many times, that physiological symptoms, or let me say it different, physiological experiences can really trigger traumatic reactions. And, for instance, cutting the grass, which someone might have done 100 times, 1,000 times, right? And then all of a sudden, next thing you know, because of the vibration of the machine or the noise or something, they're having flashbacks, or they are having some sort of traumatic reaction to something that happened years ago, or a hot shower. Just any number of physical, cues, if you will. And I think it goes back to The Body Keeps Score. It's a very popular book, by the way, which I have on my desk, so I'll show it. Bessel van der Kolk wrote it. He's a leading expert in the field of trauma and treating trauma and the research on trauma. But he talks about that, right? Like that trauma is not necessarily stored like a movie script memory. In fact, the leading thought around some of the trauma memories is there's discontinuities in our brain. There's disconnects, right? Things are not, it's jumbled, and it's a lot of it could be the sensory overload at the time, and or the brain's amazing way to try to protect someone by kind of shutting down different parts, and maybe even shutting down parts of the memory. So the body can remember this trauma in so many different ways through any of the five senses. For instance, it could be triggered. And I think you're right. Like, as women are going through these hormonal shifts, so much is happening, right? And they're having all of these different hormonal shifts. What happened, and the other interesting, and this is all this is all sort of anecdotal in my mind, but what if the trauma happened when they were in adolescence and having all these hormonal shifts back then, right? And then they're having this next big wave of hormonal shifts. I mean, that would just be one of my sort of underlying theories or questions that would be running through my mind. But to your point, more like, there's that piece of just so much of the physiological trigger, and the body has kept sort of a score on that trauma. And I think I said this in our talk with IF45, but there's lots of anecdotal evidence too of, clients that I've had personally, where you see physical manifestations of illness, of pain, of cancer, right where the traumas happen. So like if it's a sexual abuse victim, it's, there's a high correlation of pelvic pain or colorectal cancer, or, any number of, really, disabling sort of physical ailments. And while you can't necessarily say that the abuse caused it, it's just, you see it over and over again, where there's this manifestation of some sort of, physical issue, and it correlates with some sort of history that they have.
I really do agree with that. And even with what I've done, I've seen instances of this. It's just so hard, I guess, to quantify, because really all you would have is to maybe interview an individual and then connect dots.
Right.
But there's no like solid scientific, let's hook you up to these electrodes and check this out. There's really no way to quantify that. But oftentimes what we see working with individuals, and especially when we're seeing it time and time again, I think we can really learn from that, even if there isn't the science to back that up. Now, there's something called the ACE, the Adverse Childhood Experiences. That recently came on my radar about a year ago, and I found that really fascinating. Can you explain to the listeners what that is?
Yeah, it's, what this is sort of at the core of trauma-informed care training. It's this amazing study. So Dr. Folletti out of Kaiser Permanente in California, I think this is around late 1980s, 1990s. So he had a very successful weight loss program, and he was helping individuals lose, like one of the case examples is like he helped a woman go from 400 plus pounds down to 132 pounds.
Wow.
And so he had some really staggering evidence for his treatment. And what he found, though, is that when he would have this individual, for instance, came back for a follow-up, and she had gained back a staggering amount of weight in a very short amount of time. And it concerned him. And so one of the beautiful things about Kaiser is that they did very thorough histories with their clients and patients. But he sat down with her, and what he found out is that someone remarked on how good she was looking, and she went home and started eating. And then when he started to unpack even further into her history, he found out that she was a victim of incest from her grandfather. And then and what was staggering for him is this wasn't the only like he had only had in his history like maybe only a few clients talk about incest before, but now that he was starting to see his weight loss clinic results, there was some, he was seeing issues with people gaining back weight. He started to ask more specific questions about what's happening, and unfortunately started to see too many examples of individuals gaining back the weight after they were triggered, and then they would have some sort of history of abuse. And so he thought, he's like, I'm stumbling into something here. And he tried to get interest in researching this further, and actually the CDC stepped forward. And so he partnered with the CDC, and they developed this really amazing study. Kaiser has about 50,000 people go through their clinics each year, and they were able to enroll about over 17,000 applicants. And they developed a questionnaire called the Childhood Adverse Event Scale. And it only had 10 questions about different types of adverse events that you might have experienced in childhood, such as, did you have a parent who's an alcoholic, or a parent or a caregiver who's mentally ill? Were you a victim of physical abuse, sexual abuse? So there was 10 questions. And no matter how many times you might have experienced a certain kind of, let's say, sexual abuse, it was a score of 1. And what they found, I'm actually going to just read this. The studies respond, and this is also very interesting. The study respondents were mostly white, middle class, middle-aged, well-educated, and financially secure enough to have had good medical care through their life. Well, what they found through the study is that the higher your score was on those 10 points, the higher correlation you had to worse health outcomes. And they started to see things like, and again, I just didn't want to misrepresent it, but 2/3 of the respondents reported adverse experience. 87% had 2 or more. 1 in 6 had an ACE score of 4 or higher. And here, if you had a score of 4, you were 7 times more likely to be an alcoholic. If you had a score of 6, you were more than 4,600% likely to be a drug user. And so then, the thing that this really began to shift is that, we are looking at clients like they've got all these problems. Like, you're diabetic, you don't eat well, you're not exercising, you're not taking care of yourself. And we're looking at it as their problem. They've been using this as a way to cope, right? This has been their solution. The drug use, the alcohol, the food has been their solution to what's happened to them. And so it really was this paradigm shift. And that's really where the ACEs, and so the ACEs has just become this amazing tool, and they continue to research, but they can just really, it's really helping understand. It's even really helping children in school and how the teachers are relating to them, because we're starting to understand that these kids aren't coming in with behavioral problems and just not, they're not misbehaving because they just want to misbehave, right?
Right.
It's helping shift the paradigm of what's happening in their home life. And then that's how it's manifesting and showing up in school and other places. So there's so much fun about the ACEs, and you can, I think, on a public forum probably find the original study, but it was Dr. Folletti who was the main research person.
Those are staggering statistics that come out of that with alcohol, drug use, and food really is addictive, especially the way our food supply is now. It is addictive.
Absolutely.
For anyone, whether you have issues or not. And then you add that in. And then I could resonate with you saying the woman that did not want to be seen. Someone gave her a compliment and that set that off. It's interesting. I didn't experience that with getting fit, but I did going into online business. I remember thinking, and when I wrote my book, same thing. What if this is really successful and I get a lot of attention? And that wasn't exciting to me. I was like, oh
Yeah,
no,
yeah.
what will I do? It was a little scary. It gave me some anxiety. So I could really relate to that.
Hmm.
Now, who is using the ACE? Because I know I've been to numerous types of doctors and never once was given that until I actually found out on my own and took the quiz on my own online, but I had never heard of it.
Well, I think again, I mean, as large as the movement is, it's just in these, it's in these individual pockets. And so it's in order to train an institution, it's an overwhelming kind of endeavor because you really have to have top-down buy-in, and you need to train every layer of your organization, everyone from environmental staff, and everyone has, number one, either they've had trauma in their own life and it's impacting the way they relate to the world, and or they will have um, any layer of contact with a client or patient, right? And so to have every layer of your organization trained is really challenging. Then to have the providers trained is very challenging. And so you're just seeing it is, there are institutions, there are places, schools, there are hospital systems, clinics that are using it, but it's just in these little pockets where they've bought in and they've invested in the training. I think, on an individual level, a lot of providers, personal trainers, health coaches, a lot of them are afraid of the questionnaire because they're back to the question of, well, what do I do with that information? And they're afraid of it because, once you know this, then you feel obligated to do something about it. And so they're afraid, they're like, well, I'm not a trauma provider, right? I don't treat trauma, so I don't know what to do with this information. And I think that's the scary aspect for a lot of different clinicians and providers, is just what to do with the information. And so trauma informed care, and I know we had talked about this, it's really, and if my sleep technicians could figure this out in a 30-minute presentation, it's really, number one, looking at yourself and seeing if you're being triggered or how you are responding to someone and being able to watch their physical cues. And, I think we can sense when someone's getting uncomfortable. And really trauma sensitive just means backing up for a second, checking in with that person, being gentle. A lot of it can be helped by just telling the person ahead of time what you're going to do and what to experience so that they can prepare for that, and giving them permission. So it's, a lot of it is just being collaborative with your client about what's happening, slowing it down if need be, giving them permission to take a pause, giving them control where you can, like the way they face the door or not, or where they sit. So there's just, again, depending on your environment and how you are practicing, but just really being able to pay attention. Or, to your point, you talked about that individual, he looked like he was sort of zoning out, or someone shaking, or someone suddenly becoming pale, any number of sort of physical cues that they're suddenly uncomfortable, and just gently checking in and giving them space, and not pressing, but giving them space to take a minute if they need to. Um, I always, and when someone discloses, again, I'm not necessarily going to, depending on the circumstance I'm in, I don't jump into treating trauma. But if someone's disclosing it to me, I mean, I'm just very honored by it. And I share that with them. I just thank them for sharing it. And so simply just saying, thank you for sharing that. I don't know what to say, but thank you can go miles. You're just allowing that person to be vulnerable and hold space for them without necessarily doing anything. So
It's
yeah, so I
very
think that's a long answer.
it's very important, I think, to give them that space and then not to cross over, not to cross that boundary, because I'm not a psychologist, I'm not trained in that. I could actually do more harm than good. So I know I'm always cognizant, and if somebody shares something with me, I'll do what you had suggested, thanking them for trusting me enough to share. and then encouraging them to work with a professional or referring out, having some
Right.
names there that I can refer people to. And that has helped a lot. I think in the fitness, personal training, nutrition, I know when I came into it, the whole thing, I came in as a group fitness instructor, and the whole thing was, it's terrible to say, but was to make the class as hard as you could and kind of entertain people. And part of that was the yelling and the counting down, and it never dawned on me this could be very triggering for somebody with PTSD to be me up there with a microphone yelling. And same with nutrition. I've actually had clients say, well, you need to push me harder. You need to push, yell at me. And I'll say, no, 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 I'm not your coach. That's not my
Mm-hmm.
approach. I have found that not overwhelming has been very helpful. So giving them very small steps, and then if they want to take, putting the control with them, if they want to take more steps and move faster, then allowing them to do that, but taking some of that overwhelm away, because being in fitness, nutrition, coaching, initially I'm like, okay, I've got the secret to, you know, gaining the muscle, losing the body fat. I was so excited. So I would throw everything at them but the kitchen sink. And then, of course, what happened? It backfired. People ghosted, they dropped out. And I think that overwhelm was triggering.
Yeah, yeah. No, it's well, and you brought up a good point, and that is, truthfully, we could trigger someone in any like number of ways. There's no way that you could hone your practice to perfection to avoid any kind of trigger, because what I used to think about it like bright lighting might trigger one client based on whatever happened in their history. Low lighting would trigger another. So you're really not going to be able to find this perfect trigger-free environment, or even in your language. I mean, it is more about monitoring than someone's reactivity to you, and adjusting and doing a little bit of a pivot and gently asking, like, I just noticed a shift in you. Did something happen? Or, and just gently asking, because there really is no way I think we would become paralyzed and not be able to make a move, right? If we were to think every possible way that we could trigger someone. But it's really about, and we used to say this in the trainings, it's treating everyone with, we used to call universal precautions, like, everybody wash their hands in the hospital system, like washing your hands is universal precautions from spreading germs, right? Well, with trauma, I think we need to treat everybody as if they have trauma, or just expect that everybody has trauma. It's not about identifying, you have it, you don't, you have it, you don't, and I'm going to act differently according to that. No, it's about the fact that I think trauma is so prevalent, and you really do not know who has it and who doesn't from the outside. It hits every socioeconomic level. There are no predictive factors where you can, say, well, that person looks like they've had trauma versus someone else who doesn't, just based on their appearance. So it's really just being sensitive to the fact that you don't know who you could possibly, or how you might trigger someone, and just pretty much expect that everyone has some trauma in their background. So, yeah.
That's really good advice. I think treating people with respect and then setting up a safe space, a safe environment
Hmm.
to share where they know, okay, this is just between us and it goes no further,
Hmm.
and just setting things up in such a way that you can't avoid every trigger, every situation. But I think with respect and having that safe place and empathy for people, we it can really go a long way for sure. Now,
Yeah.
I want to touch, I don't want to forget to touch on this, the treatment, the most
Mm.
effective treatments for PTSD, for the more complex trauma. What are you finding works? What doesn't work?
Well, the VA has the golden standards. They've done a lot of research, and so they had, when they would think of their golden standards for treatment, it would be cognitive processing therapy, which is a heavily um, written, homework heavy kind of treatments, where they are reprocessing their trauma by writing it out in detail and rereading it every single day. It's homework heavy. prolonged exposure, which is, so if someone has a feared situation or feared events, it's like you're stepping your way, little steps into re-exposing. And then while you're re-exposing, they're learning the skills to dial down their reactivity. And then the one that I personally use the most, or exclusively at this point, is EMDR, which stands for eye movement desensitization and reprocessing. And it's a mouthful, so that's why everybody says EMDR. And the interesting thing is that when I in preparation for today, I pulled out my old textbook, and Francine Shapiro, who developed EMDR in the late 80s, I think 89, she says if she knew what she would have renamed it as just reprocessing therapy, or theory, I forget, therapy or theory, if she were to rename it today, because eye movement was the initial protocol that she developed. So what she discovered is that when someone was reprocessing, or i.e., thinking with images and thoughts and memories of a traumatic event, she was having them move their eyes back and forth by following her fingers or a pen tip. And so their eyes were going back and forth. And she found remarkable success using this, what they call bilateral stimulation. So you're stimulating left, right brain, left, right stimulation with the eye movement. But we use all sorts of modalities. I actually really do not like the eye movement. It bothers me. People with eye issues, migraines. So I have traditionally in person used hand buzzers. I don't have them with me, but they were these little electrode things that would just buzz alternatively, not shock, but just like a vibration. And I could control how fast and how strong that buzz. When a client was reprocessing a memory. Now, working exclusively remote, virtual, clients tap. They butterfly tap like this, or they'll tap their knees alternatively, whichever's more comfortable. And I have had tremendous success, no difference. And I'm not controlling the speed, how hard they're tapping or how light they're tapping. So eye movement, so EMDR sounds a little woo-woo. They have done so much research around the fact that over and over again it works. And I've been using it now for several decades, and it works. That's why I keep using it. But it's a holistic approach where I think that there's this physical grounding so we're addressing their emotional, their physical, their body reactivity to these traumatic events. And what I love about EMDR is that it takes a chronological approach. So we are looking at the earliest time where they might have had these experiences, that have sort of built. So let me put it this way. So the earlier the trauma, it may have a bigger impact even on how the brain's developing, the neurodevelopment of the child, right? And so the earlier traumas may not even have the right words, doesn't have even like sort of the adult thinking around it, because they're children, right? They're not developed yet. But these events are built upon over time. And so you layer in other, maybe even mini or big traumas on top of it. So if we can address the earlier experiences, there's just a tremendous, sorry that I'm losing my words, but they seem to have like a rebound effect where we don't even have to process all of the future memories. But you take the treatment from the earliest memory up until present time, and then even imagining a future time. And so it's just a real holistic approach. And if you have more questions about that, because I know I gave kind of a global, statement of what it is.
Now, is it combined with the talk therapy? So you're using the talk therapy to kind of unpack the earlier memories, and then from there you're layering in the well, not the eye movement, but the buzzers or the tapping or something like that.
So really good question. So typically a client will come in, and in their day-to-day life right now, they are struggling in some sort of way. And so what we can see is maybe there's some really deep-rooted negative core beliefs about themselves, the world, or others. So like, I'm not safe, or I'm not worthy, or I'm damaged. So they have like these really negative core beliefs that are triggering in their current life and causing disruption in their current life. It's causing some level of dysfunction. And so then as we actually are doing the treatment plan according to what is, so there's this component of what is happening now and what is sort of, for lack of a better word, dysfunctional in your life right now. Whether I'm worthless or I can't trust people, right? And then we are treatment planning, not exactly along those, every experience with that. Because what I have found, people typically have multiple negative belief systems that are being kicked in. It's not just one. And in the old days, we would have done a treatment plan according to each negative cognition and tried to separate out the memories, but they're so interconnected. So what'll happen is we will start with the earlier memory around, like, whether it's safety or worthiness or love or something like that. And they are centering themselves on this earlier memory along with the thoughts and the physical sensations that come up. And so we're really trying to unpack during this reprocessing stage. What we're trying to do is to dial down their emotional reactivity in the here and now. So it's never to make it okay that it happened. Never going to condone that something terrible happened, or that they have to have some sort of silver lining out of it per se. But we're really trying to get their emotional reactivity down in the here and now. So they're no longer getting hijacked, even though that trauma might have been many, many years ago. They're in some way getting hijacked today, if that makes sense, when they get triggered. Their brain and their body is responding at a very heightened, level.
That makes perfect sense. Because I know, like I talked about, that tendency to kind of bury things. But I was thinking as you
Mm-hmm.
were talking how I thought of my own past negative self-talk, which thankfully I've replaced with more positive thinking, but I carried it for decades. And
Mm-hmm.
people will quietly carry these inward negative thoughts, and they're talking to themselves in a way they would never talk to another human being or a friend or their daughter,
Absolutely.
but it's all going on. And then it almost is normalized. I'm just using myself as an example, where you go through just
Mm-hmm.
decades until something,
Yeah.
it's like all of a sudden it's like, I've had it. This can't
Mm-hmm.
continue. So I was thinking of that too. And then the other thing that came to mind is how talk therapy, I mean, I think it has that place, but it can be rather painful for the patient to go through that and almost re-traumatize them. Have you noticed that?
So I would say there's very few clients that have ever been excited to do trauma work because, to your point, they've tried to either push it away, bury it, or they may not even have clear memories of it. So they're not even sure that they'll get anything out of it. But most clients come in with a bit of resistance or reluctance to the treatment. Um, Here's the thing. The trauma is eking out typically in ways anyway, right? It isn't fully contained, or they wouldn't be in the session with me. And what I have found is that they begin to have better relationships. They begin to respond better. It doesn't mean they may be very wiped out after session, and maybe, and I've had clients that just, like, the rest of the day is a bit of a waste because they're just emotionally, physically, it's like, their adrenal system, they're just wiped out. And so I really encourage good self-care after a session. But once they get into the flow of it, I just find that clients are more and more willing to, especially when they understand what the session, they never know what to expect in the beginning, but as we do a few rounds, a few sessions, they begin to understand the flow and what to expect. And we always end session in a way to try to, like, calm the nervous system down, and to contain it as much as we can. That doesn't mean their brain won't continue to process in between, but that's the other piece, is that their brain begins to make these new neural connections. They may even remember details, important details, that put a different meaning around even what happened, when they allow their brain. So this quiet reprocessing, where I'm quiet, they're quietly, in their mind doing this, their brain is able to organically go where it needs to go. And our brain wants to heal. Our body wants to heal. It is designed to heal. So when you get out of the way, it can heal. And one last thing about that is we often think about trauma treatment as like having a splinter in your hand, right? You get a little splinter in your hand and it's there, and by initial, you just can't pull it out, and you kind of look at it and you might let it go. And the longer it's there, it may begin to fester, and it might, you know, grow some infection around it. And it may even kind of get deeper and deeper, right? So what do? You have to take a tool, open it up, dig it out, and then the skin can begin to heal over. And that's kind of what specific trauma treatment does. Digging in so the body and the mind can heal. Cleaning it out.
Makes perfect sense. And just even again, I used my own experience because that's the easiest way for me to apply what you're saying. Is yes, in the beginning, it'll wipe you out to unpack all this. But I will say this, there reaches a point where that happens less and less and less,
Mm-hmm.
and you learn
Mm-hmm.
coping mechanisms. And
Right.
if the therapist is keen to it, they know when things have gone too far and they'll
Right.
stop, ask, okay, on a scale 1 to 10, that's what my therapist does. Where are you at with anxiety? And if it's too high, we shift away for a while and come back to it
Yeah.
later. And so all of that is really, really important. And it sounds like you're using all of these modalities plus the EMDR. I just one, I know you have a hard stop, and this is just a quick one. I'm looking at the time. I know you have plans with your
Yeah.
daughter, so I want to be respectful of that. But is the EMDR something they use if they get triggered? Like, let's say they go out somewhere and they smell something, see something, hear something. Is that something they go to the tapping or something they can just kind of use as an ongoing coping mechanism?
It's funny, a lot of my clients never even think to do that. And so I'll have to remind them in a subsequent, they'll come back and say that they had a triggering moment or something happened. Like, well, you could use the tapping. And they're like, oh, I didn't think of that. So it's something that I need to always remember to tell them because they don't naturally think that they could actually tap. But there is a whole separate treatment modality called, it has different names, but EFT, emotion focused therapy, or tapping in of itself is a modality that you can use not just for trauma, but for anxiety, fear of flying, negative thoughts. And it's tapping on the meridian points that are used in Asian medicine. And it's tapping. And so yes, tapping is amazing. And so it's helping individuals find different tools in their toolbox to use at different moments for ways that will individually help them. And my whole thought is just calm the nervous system down, because when your nervous system gets hijacked, what happens is, your primal fight, flight, freeze kicks in, and you no longer can think your way out of it. So the frontal lobes, they can show on scans, the blood flows away from the frontal lobes to activate the fight, flight, freeze. So that's why people literally get stuck and they can't think, they can't formulate a sentence. They may seem frozen. And then later on, or they're in a fighting mode, they're just very reactive. But then later on, when everything calms down and the nervous system is back on track, then they can talk and process it through, but in the moment they can't. So yeah, so like to your point, tapping, whether it's just the butterfly tap, whether it's breath work, whether it's learning how to tap on the different meridian points, the tapping itself doesn't even need words. They have shown cortisol can be reduced by 30% in one session.
Wow.
So yeah, it's like there are so many different ways to get to that, but it really comes down to what a person is willing to use. So
That's
yeah,
true.
good
We're
question though. Thank you.
all
Yeah.
individuals. Well, as we wrap up, and I want to be respectful of your time, how can the listeners reach you, follow your work, learn more about you?
Oh, thank you. Well, they can follow me on Instagram. It's Dr. Tara Gunther. So Dr. Tara Gunther is Instagram and Facebook. I also have a website, so it's the same. It's www.drtaragunther.com. And thank you. I've really enjoyed, and I hope that this has been able to give some clients and even other coaches some ideas of just how to approach each other and to understand the importance of being trauma informed. Yeah.
Thank you so much, Tara. It's an important topic, and I appreciate the work you're personally doing, the work you've put in, and really just being a guest today on the show. Thank you so much.
Oh, thank you, Carol. Appreciate it.
And to our listeners, wherever you are in the world, we wish you every blessing. Bye bye.